So good afternoon, everyone, and thanks for joining us for this lunch and learn. I'm just going to continue adding people, but I'll be passing over to Seb and Datcheng soon. So the lunch and learn today is all about health economics, and we've got Sebastian Hind with us, who is a senior research fellow at the Centre for Health Economics at the University of York. If you could put yourself on mute if you've just joined, that would be great. Thank you. And Seb specialises in economic evaluation. And then we also have with Seb Datcheng, who is a research fellow in health economics at the Centre for Health Economics at the University of York. So I will pass over to them now to share their slides. And like I said, if you could keep yourself on mute, that would be fantastic. Thanks very much. Over to you, Seb and Datcheng.
Thank you very much. Can I check that you can see my slides hopefully now?
Yep, we can see them. Thank you.
Brilliant. Thank you. I'm going to hide you all. So if anyone wants to ask any urgent questions, do interrupt. We've left some time at the end of both of our presentations to go through anything that people might want to ask. So yeah, leave anything major till then. But if there's anything like my slides stop working, do tell me before I get too far into it. So yeah, thank you for coming along to this session, everybody. So as a bit of an overview of what we're going to try and get done in hopefully 40 minutes of slides and 20 minutes of questions. So I'm going to start off with doing a bit of a basis on what is health economics, how's it conducted, and most importantly, how to interpret its findings. Really structured to try and help you interpret what Dashing's going to be presenting after me, which is a bit of a project we've been working on that hopefully will be published soon, but has been under review for a couple of months on the cost effectiveness of interventions for improving medication adherence in patients with difficult to control asthma. So in my session, I'm going to try and give a bit of an overview of the intuitions and practical applications of economic evaluation. For this presentation, I'm very much conflating economic evaluation and health economics. Health economics is a much broader topic. It covers a whole range of other things, but most of the time it's used to describe economic evaluation, and that's what we're dealing with here. And as I say, the focus is on helping to interpret the asthma model, but I'll touch on some of the wider methods. But it's a very big discipline, so there's lots that we won't get into. I'll try and avoid lists of definitions because it can be very dry and inaccessible. Hopefully working on intuitions, but there will inevitably be some definitions that come up, but hopefully I suitably explain each of them as I go. There are many, many rabbit holes. I use Alice here as a bit of a placeholder for if there's a rabbit hole, that there's a very deep discussion to have. There's lots of complexities. There's lots of PhDs to be done in working it. You'll see Alice pop up so that we know that there's an area there. We know there's a big hole, but we will try not to fall down it. So people know lots, I imagine, about different elements of health economics. You hear lots of different words and phrases come up all of the time. Some people will have interpreted them differently, heard them in different contexts. It can be very inaccessible. And then a lot of the time, you just see things like this. I promise it was nothing to do with Jermaine Janus, but you see this, and this was from the back end of August. Furious dementia drug denied to patients on NHS. And the headline is always based around that it was too expensive, the benefits were too small, that some bean counter is determining how much we should value people's health. And lo and behold, it's been decided that we're not valuing health enough, so that we can't afford the latest drug. Cancer, dementia, see all sorts of these headlines come up again and again. So with a bit of luck, I'm going to try and give you an MSc in 20 minutes, which will probably be a bit tight, but we'll cover some of the basics. So the starting point is really, how do we value health and healthcare in general? And which bits do we need to put a value on, and which bits can we leave for others to do? And I'll touch on the idea of conventional evaluations, how they're most commonly applied in the UK, certainly looking at costs, so quality adjusted life years, that you might have heard pop up quite often in the Daily Mail, especially as ways of determining health of individuals, and then ICERs, incremental cost effectiveness ratios, that I promise I'll go through later. And then key to Dasheng's presentation is the idea of extrapolation and modelling, so going beyond the evidence that we've got to try and extrapolate future health. And then I'll finalize by just summarizing some of the keys that we've gone through. So valuing health and healthcare has been something that's been mused over for years, really. This first one was in response to a mining disaster. What is the fair average value of human life? Would it be right to spend £100 a head in order to save them, or 1,000 or 1,000,000? The lowest of these sums would obviously be too small. The highest would be too great, if only because of the same amount expended in a different way might do infinite more good. And that covers a couple of key aspects. It's the idea of how do we value how much we spend to improve health or to stop an event happening, and this idea of the money being useful somewhere else. It's this eternal magic money tree. The money has some value that is not being realized by using it in this way. And then the second one it quite often summarizes the view of this. And again, we saw it in that newspaper article. To be trained in medicine, nursing, or one of the other sharp end disciplines, and then faced with some hard-nosed, cold-blooded economists placing money values on human life and suffering is anathema to many. My wife's a consultant in obstetrics and gynecology, so we very much bridge that sharp end compared to cold-blooded divide. And then this last one, I hate to pick on the Daily Mail, but they make it very easy at times. If 1 year's life is worth £30,000, that implies the value of a whole 81-year-old life. The average life expectancy in the UK is around 2.4 million. So it's again this, is it right to be putting some value in pounds on the health and life of some individual? But actually, fundamentally, to how economic evaluation works, certainly in the UK, is the idea of making relative comparisons, not absolute, so that we're not talking about an individual's health is worth so many pounds or their life is worth that amount of pounds. It's comparing two different realizations on the world, often two different cancer treatments or something, or an intervention and not intervention. So conventionally, health economics or economic evaluation takes the healthcare budget as fixed and focuses on comparing the interventions competing for the same pool of money. So that's to say the size of this NHS treatments bed is fixed. So we just need to compare what's coming in from what's going out. So is the thing that's coming in worth doing, both in terms of is it the best, most cost-effective way of treating that patient, but also is any additional funding that might push someone else out of the treatment bed worth the implications. And yeah, we take the size of the bed as fixed and really pass it further up the chain, that it's a government decision how much NHS funding is. So therefore, it's by extension a democratic decision. The NHS funding is always something that comes up in debates and whenever we have elections. And at what point are we not willing to spend any more NHS funding and fundamentally not willing to spend any more investing in people's health? It's much more complicated in countries with a mix or with mostly private healthcare, and whether that's related or not, economic evaluation has had much less traction in those sorts of countries. Again, big rabbit hole that we won't touch on for now. So where does that leave us in how we can think about health if we're not valuing the health of the individual as such? So if we're not valuing health of the individuals or society, we can just compare the relative costs for gains in some desirable outcomes. So every intervention has some cost implied by it, but also some beneficial outcomes as to why we want to do this treatment. So if we're comparing the two different people trying to be in this bed at the same time, there's these different approaches that you might have heard used before. So the most simple really is cost minimization analysis, where we're just comparing the costs of those different individuals alone. Of course, the trouble is if we're not comparing the benefits, you end up with a race to the bottom where the cheapest intervention is always the one that's chosen. To add a slight layer of complexity, you have cost consequence analysis, which is then just a statement of the costs and outcomes between different interventions. So we're not trying to weigh off the merits of different outcomes. We're saying, for example, intervention A improves hospitalizations, but intervention B improves mortality rates, which is good at bringing in this idea of benefits, but it's obviously very hard to trade off apples and pears or hospitalizations and mortality. So then the next layer is cost effectiveness analysis, where we're trying to do direct comparisons of the cost per single outcome of interest. So we've most typically got some measure of health. The leading option as a single measure is this idea of quality adjusted life years, which we'll give more details on later. There are many other different ways of creating these sorts of frameworks to conducting economic evaluation: cost benefit analysis, return on investment, societal return on investment. But there's fundamentally the same idea of getting the most benefits for the least cost. So carrying cost effectiveness analysis forward, it has three principal questions. What the cost of the funder is, so the NHS in this case, and this is the intervention versus some element that we're comparing it to. And then the amount of additional health benefit that it's likely to entail, again, with this comparison between intervention and comparator. And then what else can we spend the money on? This idea of opportunity cost. So as was presented early in that mining disaster thing, the idea that the money has some value somewhere else in the NHS system. So rather than the cancer drug that we might be considering, how else could it be spent? So would it reduce the amount of new hip implants that we could do? So question one, cost to the funder. This is typically the nice, easy place to start. So the costs are normally framed as the direct cost of the intervention, plus any costs of other healthcare use, so GP and hospital visits and so on. So the cost of the intervention is sort of the cost of the drug or the surgery up front. And then the other healthcare can be GP visits, hospitalizations, as I mentioned, and then it can be calculated or estimated in a number of different ways, from clinical records or trial data or through patient questionnaires. There's an example here of what a typical patient questionnaire looks like, where you ask, over the past 6 weeks, how many times have you seen your GP, seen them at home by phone, and so on. You can ask a whole range of questions depending on the topics of interest. So then the second element, the amount of additional health benefit that it's likely to entail, this is where it starts to get a bit more complicated. So again, this idea of how do we value health in ways that we can compare. So we're not wanting to necessarily value health in terms of put a monetary value on it, but just put a number on it so that we can compare someone's health today with someone's health tomorrow. In specific diseases, you've normally got quite good clinical outcomes. So everything from blood sugars to CD4 counts, or disease-specific measures, so the SAC and WOMAC in angina and arthritis. Or a policymaker quite often might have a specific administrative target, so reducing readmissions to a certain level or delayed transfers of care. But neither are really health as the public imagined it. If you ask someone on the street how healthy you are today, they don't automatically go to things like, well, did they go back into hospital? They've got some idea of how they're feeling, how they're able to perform their daily activities and so on. So this led to the development of generic health outcome measures. You might have heard of the EQ5D, which is the most commonly used and comes in different versions. And then there's other things like the SF tools, which aim to really just tell you about the quality of life in very general terms that you can then compare between different individuals and different interventions. So then you can combine this idea of quality of life with some idea of how long that quality of life is achieved for, to get this idea of a quality adjusted life year that comes up again and again in economic evaluation. For the sake of this presentation, I'm just going to focus on the EQ5D3L. It's the most commonly used generic measure and is also recommended by NICE. So you see it a lot, and it's largely unchanged for over 30 years now. The questionnaire itself, and I'll show you what it looks like, has 5 parts, each with 3 levels of different health individual, and that gives you 243 different health states. So this relatively simple questionnaire gives you quite a wide number of different health states that it can explain. You can then take those different health states and put a number on it, a quality of life, a score that in the UK, as has been estimated, runs between -0.594 and 1, where 0 is this equivalent to dead state, which is inevitably very controversial, and then 1 is the best health imaginable. So therefore, anything that's a minus value is where your health is so poor that it's equivalent to being worse off than dead. So this is what the EQ5D questionnaire looks like if people haven't seen it before. So you've got these 5 different domains: mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. And then each one of those has 3 different levels. So I have no problems, I have some problems, and then I'm sort of confined to bed, or I'm unable to wash, depending on the level. So you get to the score from this questionnaire by essentially ticking off the different values. So you might be in an extreme amount of pain but relatively mobile, and you filled out those 5 different levels, and you've got these different levels. So 1, 2, 1, 3, 1, as you've ticked out the boxes. You then have this definition of a black box calculator that takes those scores, you put them in, and it coughs out some number that tells you the quality of life based on those responses. That through a series of regression analyses, they've worked out what those responses to the general population look like in terms of this score between 0 and 1. So inevitably, based on those responses, the person's quality of life at that point is very low. You can then, as I said, fill it in over a period of time. So this is a slightly simpler example where we've got these 3 different time points: time point 0, 0.5, 1, and then 1.5 for both a usual care and a new intervention. And the way you calculate the quality of life score from that is you essentially join the dots and work out the area covered by the two different interventions. I won't take everybody through the maths, but you'll have to trust me that if you work out the areas covered by those different joined up areas on the graph, you end up with the usual care has a quality score of 0.85, so that's the orangey area, and then the intervention, which is covered by the orange and the grey area together, has a quality of life score of 1.5, so that's the highest quality of life score over the entire period that they could achieve. So you get this incremental QALY value of 0.65 by working out the difference between the two. So that's the first 2 elements of cost effectiveness analysis. Now comes the really difficult one, where what else could you spend it on? What's the opportunity cost of this spending that you did on this specific intervention? So we've said we know that the comparative cost and health benefits between 2 interventions. But if the better option costs more, as is often the case, so the new cancer drug or the new way of doing a hip operation, what is the implication of that additional spend elsewhere on the NHS? It will reduce activity or health somewhere else in the system. So how do we make sure we're including that? So we need to know the health gain from this intervention and how it compares to the health loss from what we'd have to stop doing. So in the example of the 2 patients trying to get into the bed, it's the person that would be pushed out somewhere else in the healthcare system as a result of the new person entering. So it's quite often conceptualized as these 2 different hurdles. So we've covered the new treatments better than the first one, but there's this second hurdle of, is the extra cost worth it to the NHS? It would obviously be lovely to know how all of the interventions in the NHS compare and the cost effectiveness of everything we do. So if we have to fund one new thing, then we know what it will be displacing. But unfortunately, we don't really know that. So we've got to have a bit of a workaround. So we work out the incremental cost effectiveness ratio, which always sounds very complicated, but it's actually a relatively simple idea that you just need to work out how much it costs to gain 1 extra unit of health with the intervention. So it's this quite simple idea of how much it costs over the health gain from this new intervention. And then the second step is to compare this ISA, the incremental cost effectiveness ratio, with the same thing that we'd have to stop affording. But as I mentioned, we can't observe what that thing is that's pushed out somewhere in the NHS. It might be pushed out straight away, or it might be pushed out in a couple of years' time when budgets are tightened up. So instead, we've got these idea of cost effectiveness thresholds, which, again, people quite often have heard from because they pop up in media circuits quite a lot. But we don't always know what will be stopped. So instead, we use this threshold, which is a cutoff below which taking money from other current services is worthwhile, but above it's not. So it's a very definitive threshold. There's a lot of rabbit holes about what it is and what it isn't and how we calculate it. But for simplicity, There's a link there to a animation that I made many years ago trying to explain some of this. So it's yeah, if people are interested in more of the details, they can find it there. But there's essentially these key values. NICE. So NICE use a lot of economic evaluations to inform their policy decisions and their recommendations about new drugs, especially. And they use a threshold value of 20 to 30,000 pounds per QALY. So essentially, any ISA that we generate of a new interventions that's below that cutoff value is considered cost effective. So we accept that it costs more than what we're doing at the moment, but it is more cost effective than what will be displaced somewhere else in the NHS. There's then this alternate estimate, the one by Carl Claxton from 9 years ago of £13,000 per QALY, where the NICE value was never actually estimated. It was a bit of a guess, a bit of a let's start with somewhere and see how we go, and was never amended. Claxton et al. Actually tried to put a value on it and found that the threshold value was much lower than NICE were implementing, and that again has lots of implications that we can leave for another day. So that is the main bit of my first introduction. I'll go on to extrapolating in a moment, but to summarize this first bit, the aims of economic evaluation is to provide an estimate of the healthcare costs and some generic quality of life impacts using a framework that can be consistently applied across the NHS in a really sort of open and replicatable way. But then this can be extended, and the most simple extension that we'll be considering today is going beyond the time frame of information that we've got. So what if we've run a trial, but actually the difference in the treatment goes beyond the trial data that we've got? Either people are still alive and experiencing health differently in the two different arms of the trial, or actually some main health impact hasn't happened yet. This happens a lot with arthritis. So arthritis might not occur until 10 years after an intervention, but we don't really want to have to collect trial data for that 10-year period before we conclude what was the best treatment at that starting point. And NICE explicitly asked for a lifetime horizon in their analyses of interventions. And importantly, without extrapolating anything, we assume that any differences stop at the end of the trial period. So there's broadly two options if we don't want to fund a longer trial or follow patients up for longer. You can either draw a line through it. So you see in that graph there, the dotted lines are data that we've got from a trial, and it's possible to put a nice neat line through it and then say that's what continues to happen with those interventions. We're not dealing with that approach here. We're instead modelling it here. The idea of modelling it is the idea that if you can work out what the pattern of the disease is and how it develops and how the treatment and the intervention that you're looking at impacts that disease development, you can then model it and extend it however you like. So to start with, you design a model of how the disease works for the outcomes you're interested in, and then put in as much evidence as you can find, and that can include expert elicitation and opinion, and then turn the model on and hope it fits. You might hear terms like Markov modeling, decision modeling, transition probabilities. Again, lots of rabbit holes, lots of technical terms that we'll sidestep. This is the most simplest version of models that you tend to see, but actually incredibly common in cancer analyses, where you've got this simple three-state model of whether the individual's cancer hasn't progressed yet, so they're progression-free, whether it's progressed or whether they have died. And you just estimate the different chances of you moving between those three different states with the new treatment and with whatever you're comparing it to, and you can extrapolate that for as many years into the future as you want, or until the entire population's reached the dead state. This is absolutely key, and people will have heard it a lot. All models are wrong, but some are useful. These models are not very good predictors. There's so much more complexity on an individual level that goes into health outcomes, but their aim is to take what we know and to extrapolate the implications of that. So if we know that a new treatment improves the rate of progression by X, then we can say, okay, if that's the case, and if that's what we believe the benefit of it is, what does that look like into the long term? Okay, you'll be glad to know I'm on my penultimate slide now. So we've seen this before. Key takeaway messages. We're not looking to value life, but instead comparing the changes in health and the costs that it entails, really mostly to the NHS in the UK setting. And that fundamentally, the principles are the same as your weekly shop, really, with a limited amount of budget. So the NHS budget is not unlimited, as everybody knows. How do we try and get the best balance of what we want and what we need to buy? And yeah, if you take one thing away, take away that image of NHS treatments, that it can't all be afforded. So we're trying to fairly work out what is a effective and cost-effective way of funding different interventions. Thank you. I will at this point just advertise that I'm also, as well as my work with ARC, part of the NIHR-funded research support service, which provides support for research development. So if anyone's struggling to get off the ground with or has a research idea, either drop me an email, or that email there or that QR code takes you to the Yorkshire and Humber RSS website. Happy to have a chat. At that point, I will pass over to Dashang unless there's any burning questions. Okay, Dashang, do you want to take over and we'll...
Yes, yeah, hi. Thank you for the introduction. I will just share my slides first, I think.
I think, Seb, you might have to unshare
Yes.
if that's okay. That's it, yeah. So Cheng, it should be fine for you now.
Okay. Can you see the slides that I'm sharing?
Yep, that's great.
Okay. So good afternoon, everyone, and thank you for joining today's Lunch and Learn. I'm Dacheng, and I will be building on what Seb has just introduced about the economic evaluation and walk you through a case that we did before about the cost effectiveness for improving the medication adherence for patients with difficult to control asthma. So to start with, I think we need to discuss something about the background for the asthma disease. So it's a chronic condition that will affect, that is affecting about 12% of the UK population. In particular, in England alone, it accounts for 2 or 3% of primary care visits and 60,000 hospital admissions, and resulting in 1,200 deaths annually. So what is crucial to understand is that for us to understand here is that the poor adherence to prescribed treatment is a very significant factor behind this kind of hospitalization and death. So there are a very large proportion of the asthma-related hospital admissions are linked to this kind of bad medication use. So with that context in mind, so we are examining how improving the medication adherence can lead to better health outcomes and create potential cost saving for the NHS. So as you may recall from Seb's introduction that economic evaluation in healthcare help us to determine whether the benefit of intervention justify the cost of doing that. And in this case, the intervention we are aiming to do is just the intervention to improving the asthma adherence. And the comparator was just the current standard where the adherence remains lower. And because asthma is a chronic condition, and we need to assess very long-term health outcomes and the associated costs. So here we build a model to extrapolate the result over a 20-year period. So to achieve this, we use a macro model that Seb just mentioned. It's a mathematical approach that often employed in health economics to simulate the disease progression over time. So this model would allow us to simulate how these patients move between the 3 key different levels of asthma control, like the controlled, partially controlled, and uncontrolled, along with the possibility of exacerbations and even death. So it's just simplify how this disease will process using this model. So we are using a weekly cycle, which means that for every week, we expect that these patients, they may shift between different health states, like different control states. They may get exacerbations and they may die. And based on what we know, that for the definition of these health states, it is from the guideline of the Global Initiative for Asthma. That is, if a patient in the past 4 weeks has these kind of the fall symptoms that they got, like daytime symptoms more than twice a week, any night, walking due to asthma, or the reliever needed more than twice a week, or any activity limitation due to asthma. For these kind of things, if none of them below happened, we define them as a control state, but 1 or 2 happens, that is a partially controlled state. 3 or 4, that is uncontrolled state. And for the exhibition mentioned in this model that defines the deterioration in asthma, requiring treatment with the oral drug, and also all this kind of emergency department visit or hospitalization were distinguished. So what we need is just based on what the current evidence of this disease and estimate, under different adherence level, the probabilities of transition of patient between each states that might change. So we let the model to run like 20-year time horizon. Then we are able to know that for how many people will spend how much time in each state. And in each state, if we know that in each state, what kind of cost, what kind of health benefit we know, then we can calculate, estimate in 20 years what this kind of disease will generate the cost and the health benefit. So like we said, the population we are starting for is for the difficult to control asthma patient from the perspective of NHS and personal social services. To make this model work, we also need to make a list of assumptions. Like here that to make it practical, we are assuming that the differences in duration of acute asthma exacerbation and hospitalization do not make any differences in the transition probabilities between the different health states. And the exacerbation severity is mutually exclusive, although it was possible that for a patient who may have one type of exacerbation in one, or maybe have 2 or just more than 1 exacerbation in 1 cycle. And we also assume that the adherence level of patients do not change over time, regardless of the health states. Because in reality, that for some patients, after they experience an exacerbation, when they come back to a controlled state, they may decide to improve their adherence. But here, to simplify the model, we are assuming that they do not change over time, so that we can study that the intervention, when they change the adherence, what kind of outcome it will generate. And we also assume that the asthma-related deaths only from the exacerbated patients. And to understand that how these kind of patients, when they transfer from different health states, how this kind of probability will change based on different kind of adherence level. We just use a previous developed study that we found that they have a very good estimation on how this kind of relation will change. So it is a nonlinear relationship between the treatment adherence and effectiveness, as shown in this figure. That for treatment, when the adherence is below 30%, it thinks the effectiveness is just at the adherence rate. But when it's between 30% and 100%, it has a function for that, which is nonlinear. And when it's 100% adherence, we think that the treatment will generate 100 effectiveness, as study shows. And now we have built this kind of model. Now we need to incorporate what we know, the evidence we have into this model. First of all, so to simulate the real world situation, we just need the model to start with a real world distribution of patients. Like according to the Asthma UK study, that is the current distribution in the population of UK is 20% around from the control is currently controlled, around 39.4% for partly controlled, and 40% for uncontrolled. So we just start this model with the population in these kind of health states. And we also incorporate the background mortality rates, because even without the asthma, people may naturally get into the die mode because of the kind of natural mortality. And also we put a life expectancy on that, because people that they may die before the end of 20-year horizon. And the entry of the people at this model is 43 with our assumption. And we assume that 50% of male and 50% of female. And we are just doing this for population size 1,000, so that we can be clear about a result on the whole population. As I mentioned earlier, that this model just provides information for over a 20-year period, how many patients will be in different health states and for how long. So for fully understand the cost and health benefit, we need to evaluate what kind of costs and health benefit in each health state. So first of all, the health benefit, we rely on previous studies that they just measure this kind of health utility, use a tool that Seb just mentioned called EQ5D. And it helps us, and with this kind of data, we can calculate the quality adjusted life year, which shows both the quality and the quantity of life, allowing us to compare this kind of health benefit. Here for the controlled, when we say 0, it means that that is they get a fully health state value, and for partly controlled, they just lose this much, and for patient experience exhibition, they just lose another 0.120 health value. And with that, we calculate the quality adjusted life years as a health outcome. And for the cost, for the cost of each health stage, we need to consider several components, like the cost of maintaining this kind of asthma control, and the cost for the outpatient follow-up visit, and for the cost of treating each exhibitions. So to estimate these costs accurately, we need to understand what kind of healthcare resource use patients get. Like, for example, that we look at what kind of medications patients are prescribed, how often they need them, and what kind of treatment received during the exacerbation, and combining these kind of resource use with the current NHS pricing, so that we can estimate the total cost for each health stage. And with this kind of data, we get into the model, we are able to get a result like this. So here above, in the above graph, we just put 2 example situation when we compare, like, for patient with 70% of adherence and patient with 50% of adherence, what kind of result will be. For the cost of 70% of adherence, the cost will be like around 16,000 pounds, and with 11.63 QALYs. And for the 50, there's another number with the cost of an increase and a little bit less QALYs. So there's a difference, which means that when we improve the adherence from 50 to 70, we have less cost and a little bit more correlates that is measured as 0.19. So remember that in this case, we haven't bring in the intervention of the adherence. We just say that when the adherence improved from 50% to 70%, what kind of cost and health benefit will be. So if you got a intervention that comes with a cost, you would say that to justify these kind of intervention, when you improve it from 20% for the adherence, you need to justify the cost, because the cost will be naturally saving around £2,000 because of this intervention. And because we have this kind of relationship between the treatment effectiveness and adherence, actually we can build this kind of relationship for all these kind of adherence level and all this kind of health outcome level. As here below in the figure, we first show that for the total exhibitions over 20 years, when the adherence improving, there's less total exhibitions with the improved adherence. And on the right-hand side, that is for the cost, it is also has less cost with the improved adherence. And here in these two graphs also shows that the adherence leads to a reduction with the improve of the left years and the improved of the quality of adjusted left years, which means that when the adherence is getting better, the health outcome is getting better. So all we need to know is that when we have intervention, whether we can justify the cost and the health benefit. Yeah, so in conclusion, the model standing underscore that the potential economic and health benefit of improving treatment adherence in asthma management. And of course, all these kind of models has this kind of uncertainty when we are trying to incorporate this kind of counter evidence into this model, and because we are oversimplifying and doing these kind of things, so it is also important to address the uncertainty in the long term. Okay, thank you. That's the end of this part. I think for any questions, we are very happy to answer.
Yeah, thanks very much. Thanks very much, Dr. Cheng and Seb. If anyone's got any questions, if you you can write them in the chat if you want, or put your hand up, and I'll try and funnel those for you. That was really interesting, and just to let everyone know as well that if you were a bit late, it's absolutely fine because it's being recorded and it'll go on our YouTube channel later on this week, and I'll put the links in the chat for that. So has anyone got any questions? I've got a hand up from Chris. Chris, if you want to go ahead.
Hello, I was wondering if you could recommend any health economic courses for statisticians that might be useful, because I know there's a few aimed at clinicians, but whether there are any aimed at statisticians.
Oh, that's a good question. I will, yeah. There's a plethora of courses now, as everything's gone online as well. There's all sorts of them popping up over the place. We do run courses from Che, both in person and remotely, that aren't just really aimed at sort of working health economists. We get people from a range of backgrounds, and especially if you're a statistician, I think you'd have everything you need to do some of the beginners courses. So I can put the link in the chat to those if that would be helpful, and I'll keep an eye out for other ones and see if there's any suggestions.
Yeah, that'd be great. Thank you.
Thanks, David. You've got your hands up.
And
sorry, Dachin. Sorry, you're gonna jump.
Personally, when I just as a student, when I catch up on these kind of health economic things, I find there are some YouTube channels that are very helpful in sharing these kind of things. They are very there are some courses, some people, they just use Excel to show you that how when they build a model, how these things have changed. It's very helpful to understand that not only about this kind of theory, but also how these kind of models work. So I think I would also put the link in so that it's very, because it's a free version to have a start with, I think. Yeah.
Thank you.
And Seb and Dacheng, I'm just checking that you're happy for us to send you slides around as well. Because we could, if you've got any links, you could send them to me and I could include those in the evaluation and the slides that I'll send around after this, if that's okay.
Yeah, it should be fine.
Fab.
Yeah, of course.
Lovely, thank you. David, you've got your hand up.
Hello. Sorry, that was really great. Thank you. So in the slides there, you talked about, I think that mostly think about where we're going, right, well, this costs this much more, but we think it's this much more effective, and so is it cost effective? Can we do it the other way around as well? So I'm from a mental health background, and kind of lots of our interventions aren't very scalable, they're very intensive, and that kind of thing. Can we just sort of apply the same logic and go, well, look, we've maybe lost a little bit of an effect here, but this thing it's this much cheaper, and so it's going to be this much easier to provide. Can we do the same kind of maths for that as well?
Yeah, you can do, it's the joy of the maths, you can do it all in reverse. You've got to be a bit careful sometimes that you don't get your signs muddled, because if it's less expensive and less effective, you end up with a positive sign, which obviously has very different implications than something that's more expensive and more effective. But you can easily do it backwards, and you can use the same threshold estimates in reverse. So to tell you the point at which something is saving enough money that it's sort of, yeah, you're gaining a good benefit somewhere else. From the NHS is very good at using odd bits of money that are lying around. They'll happily pick up things to provide other services.
Great, that's brilliant. Thank you.
Lovely. Has anyone else got any questions? I sort of point out to everyone as well that on our website we do have links to the health economics theme and who the people that are in that theme, and I think it's really good that we can offer that service to ARC projects as well. So please do check that part of the website out. We've got a hand up from V Baxter.
Hi, yeah, so I'm Vanessa Baxter from York St John University. We do quite a lot of evaluations that build heavily on qualitative data, and I was just wondering, obviously your model is mostly around quantitative data, either from sort of the costs or the kind of various measures you use. Do you have a way of incorporating some of the softer outcomes and more qualitative data, or is that more used on your assumptions and your judgment as to how the model might work?
Another very good question. That I did actually have a slide on sort of including qualitative work, because I do quite a lot of trial analysis, and there's sort of two elements. It can be directly inputted into the model development and the values that are derived and scenarios that you run around the different model. There's also a bit of work that, again, I can pull a link out of, looking at how realistic evaluations match with economic evaluation and how the two can try and come together. In trial analysis, we do try and make sure that any stories that come out are consistent, that it's not that the economics is saying one thing and then all the qualitative work is saying something completely different. So it's trying to get everything in the same story arc, really. I can share that link.
Great, thank you. Has anyone else got any questions? I'll just check the chat. Oh, we've got a question in the chat that said, what would be the first page headline in the newspaper if these results were published tomorrow?
Yeah, and we are aware that we have got to be careful, and increasingly we're aware that we've got to be careful what the headlines can be read. There's a lot around how a lot more effort needs to be put in improving adherence to medications that are already funded, I think. And yeah, how you can do that. We've tried to not look too much into what interventions might look like, because it's not necessarily a space for needing more interventions. It's doing better at implementing some of the things that are already there. But we'll see. You'll see in a couple of weeks when the paper's published, Asim, you can see what the Daily Mail say.
I will be keeping an eye on that as well. Lovely. Any more questions? Okie dokie. Well, thanks so much, Seb and Datcheng, for that. Like I said, we will put the recording on YouTube. We'll send it round with an evaluation, but also the slides and any links that Seb and Datcheng can give me for courses. And if you want to get in touch with anyone about anything that's in this webinar today, you can just email the ARC email address and I will channel the question to wherever it needs to go. So thanks ever so much and go and enjoy the rest of your lunch, everybody.